Good morning, everyone. We're just going to give everybody a moment or two to log on, and we'll begin shortly. All right. Good morning, everyone. Thank you so much for joining us for virtual insights on kidney transplant. Our topic today is navigating the transplant evaluation process, what you need to know. Our speakers are Judith Hambledon, Chief Transplant Coordinator, and Eliza Bensley, Clinical Transplant Educator. We encourage you to submit your questions in the Q&A section. Today's session will be recorded and sent to all those who registered. It is my pleasure to turn things over to Judith.
Morning, everyone. Next slide, Eliza, please. So I'm going to give you a little bit about the history of kidney transplant and how it's evolved in the 50 years since the original transplant. So the first transplant was a living donor transplant, and that was performed in Boston at Brigham Hospital, and that was in 1954. And so I'm saying 50 years, it's 70 years, goodness. So it's 70 years ago. And this was between two identical twins. Back in the 1950s, we really didn't have any type of medication that would stop an organ rejecting when it was transplanted. So, but with the identical twins, that worked very, very well. In 62, Brigham Hospital performed their first deceased donor transplant. And as I mentioned, the immunosuppression was in the very, very early stages. The only thing we had in the 60s and 70s was actually the steroids, the prednisone. In 1963, here at New York Presbyterian Cornell, we performed our first living donor kidney transplant, and that was the first in the metropolitan area. In 65, we performed our first deceased donor kidney transplant, and that was the first deceased donor transplant in New York State. In 1972, Medicare started the coverage, the financial coverage for kidney transplant and for dialysis, so that was huge. In 1983, cyclosporin was approved by the FDA. So this really was what put kidney transplant into mainstream. Once cyclosporin was available, our success rates went from about 50% when we only had the prednisone up into the 90%, which is pretty much where we are now. In 1984, New York Presbyterian Cornell performed their 1000th transplant. And in 1986, hospitals were required to identify donors and approach family, giving the option of donating the organs of their loved ones. And so this is now medicated by Medicare, and the hospitals are audited. And if any person in the hospital dies in a condition that they're able to donate organs and their family is not approached, that hospital actually loses their Medicare coverage. So it's taken very seriously in the medical community. Next slide. This is just a graph of all the transplants that we've done. And I thought, to take a look at it over the last 10 years, how the trends have changed slightly. For instance, if you look at 2016, that was the year that we did most living donor transplants, and we did over 150 that year. And now you look to modern day, we're actually down to 105 living donor transplants, but our deceased donor volume has gone up. So we did 181 deceased donor transplants in 2023. So our total volume was 286 transplants, which is actually the most that we'd ever performed at our center. Why these trends, where one year the living donors are much higher than other years? We can only attribute it to things like in 2008, when the there was the collapse on Wall Street. People lost their jobs, they lost their health insurance, and we did see quite a drop in the percentage of living donor transplants being performed. And then this drop-off, this latest drop-off, occurred during 2020, which of course was COVID. So it seems to be, if there's something major that happens that can change the economy, that really does seem to change how people are able to donate. Next slide. So let's talk a little bit about stages of kidney disease. For any of you that were on a month ago, some of these slides may be similar, but I think it's still important that people have a good understanding of what this is all about. So people without kidney disease, stage 1, it's where you have an estimated glomerular filtration rate of 90 or higher. Kidneys are working well, there are no issues. Stage 2 is where your GFR drops to between 60 to 89. This is showing just some very mild kidney damage, but again, your kidneys are working well, and you'll be completely unaware of this unless you actually go and are checked at your physician. Just to reiterate a little bit about a GFR, what a GFR, this is an estimated value that we're talking about, and what it takes into effect is your gender, your race, it takes into effect your body surface area and your age. And using those with the creatinine, an estimated value comes out. Again, normal is 90 and higher, and you're going to see as we go down the different stages when you've actually got kidney disease. So stage 3A, this is where your eGFR is 45 to 59. And this is showing a real mild to moderate kidney damage. Your kidneys aren't working as well as they should. But again, you're probably not aware of this unless you actually go ahead and get your blood checked. Stage 3B is GFR of 30 to 44. This is where there's moderate to severe damage, and the kidneys, again, are not working as well as they should. But it wouldn't surprise me if when you get your levels checked, you're still unaware of it from a symptom perspective. Stage 4, this is where your GFR is between 50 to 29. And I'm going to say right now, this is where we would most like to evaluate patients for kidney transplant, optimally when your GFR is greater than 20. But we're going to talk about that a little bit more later on in the slides. This is severe damage. Chances are your kidney's not going to get better. And the kidneys are really close to not working at all, which is what we regard as the end stage. If your GFR is 15, some people will, in fact, I think the majority of people, if they're honest with themselves, would certainly be having some symptoms. Some people say they're not, but that, I think, is because your kidneys don't tend to fail overnight. It takes months and years for them to fail. And so you get used to having a higher GFR, or I'm sorry, a lower GFR than the majority of the population. You know, people come in, they've got a creatinine of 3, they feel absolutely fine. If you give me a creatinine of 3, I'm not getting out of bed. I would feel awful, nauseous, and all kinds of different symptoms. Stage 5, this is where your GFR is less than 15, and this is obviously is the most of the severe kidney damage. This is the end stage. If your kidneys are continuing to work, they're certainly not working well. And most people, if they're not actually on some form of renal replacement therapy or dialysis, when the GFR hits 15, it's going to be very, very soon. Next slide. So what causes kidney disease? I think it's, if we were to audit the people that are on today, certainly diabetes and hypertension combined are by far the most common cause of kidney disease. And if you look at 73% between the two. Other causes fall into a 20% range, and then the unknown cause, which is more more common than you would think, is 7%. So, the most common causes, glomerulonephritis is sort of a coverall for multiple things. Inherited diseases, polycystic is the thing that springs to mind, probably the most common. We see congenital abnormalities, and that's where you have anatomic malformations. This is where most of the time it's children that are born where the ureters may not be in the right place in the bladder, but something that ends up damaging their kidneys. The autoimmune diseases, lupus, I think, is probably the most common. Kidney stones, if you have them in both kidneys, it can be quite dangerous, and it can do a lot of damage to the kidney parenchyma. Renal tumors, if there is a cancer, certainly up until very recently, we saw a cancer in a kidney, the whole kidney used to be removed. I think we've been, medicine has advanced, and we are able to do laser surgery for some of the easier tumors. But if that's your issue, it can recur, and so that's also a common cause of failure. In our male population, the urinary obstruction, very often caused by an enlarged prostate. And repeated kidney infections, this isn't something that should go untreated. If you're having repeated infections, you should have a complete workup to find out what's causing the infections and get that treated. Next slide. So who's eligible for a transplant? Well, that's a pretty long list. So as we already mentioned with the GFR, if your GFR is 21, it means that your kidneys are failing, but they've not failed yet. And you are on the verge or on the cusp of being eligible. Once your GFR reaches 20 mils per minute, at that point, you are now eligible to be put on the list. Now, why is this relevant? Because we do see a lot of patients once they start dialysis, but from the time that your GFR reaches 20 to when your GFR is in the low teens and you need to go on dialysis, that could be several years. And so it's several less years of waiting if you're waiting for a deceased donor. So the sooner in the process you come and get evaluated, you get listed as soon as that GFR reaches 20. If we don't list you, then that time is indeed lost. The other thing with transplant, we have to have a support person. This is something that our social work department are very strict about, and there's got to be someone 24/7 that could give you assistance if needed. So the things that can rule you out: active malignancy. But again, this is somewhat of a tongue-in-cheek. If it's prostate cancer and you have the prostate cancer treated, we just need that PSA to come back to 0. And at that point, you'd be eligible for transplant. So many times, if you do have a malignancy or a cancer, we can treat it and then we can get you placed on the list. The same with infections. If you have a cellulitis or an osteo infection of the bone, we have to get rid of the infection. But once the infection has been treated, then you're eligible again for transplant. Inoperable cardiac or vascular disease, this is a much bigger problem. I think the term speaks for itself. It's inoperable. There's nothing that we can do. And from a cardiac perspective, the surgery would be a risk to your life, and we'll never put your life at risk for a transplant. And vascular disease, this is where we'd not be able to actually place the kidney because your blood vessels are too hard, and we wouldn't be able to put a kidney in. Active substance abuse, so be it alcohol, be it drugs, if you are still using, then that would be a contraindication to having you transplanted. Lack of adequate financial insurance or medication coverage. There have been instances, of course, that people have lost their insurance coverage, and it can be a real hardship. There's certainly no advantage to getting a transplant and then losing it almost immediately because we're not able to supply you with your medications. and social or psychiatric instability. Both our social worker and psychiatrists do need to give us the thumbs up to make sure that you're stable to list. So those are the main exclusion criteria. Other than that, it's pretty much anyone can come. One thing some people may be asking about is age. We do not have an age cutoff, but as everyone realizes, age is very relative. So some people that are 50 wouldn't be eligible because of their illness, and yet we've transplanted people into the high 70s. So age in and of itself is not a cutoff at this center. Next slide. So the evaluation, as mentioned before, the ideal time for us to meet with you is when you have your GFR over 20. By 30, that's probably having you come a little early, but we don't want to leave it until you're 19, and then your evaluation takes 6 months, and you've lost 6 months of your waiting time. So in an ideal setting, I think 22, 23 with the GFR. But not everyone has that luxury. Some people don't even realize they've got kidney disease, go to the emergency room thinking they have flu and find out their kidneys have failed and start dialysis immediately. So again, this is ideal, but not everyone has that luxury. The way we start the process here is we send candidates an online registration. We're asking for demographics for your referring physicians, your insurance, the dialysis center, if appropriate or applicable. And we also send a living donor questionnaire for those fortunate enough to have had someone mention that they may have a living donor. And this is followed by telehealth visits. We do visits with the transplant coordinator, with our financial coordinator. You get your education done over telehealth, so you can have as many of your family there as you'd like to listen in. And we also review your medical history, the medications that you're taking, and if you're on dialysis, when, how long, and where. Next slide. The on-site visit, you will be meeting with most of the team. First of all, the transplant surgeon. This is a surgeon that started in general surgery and then specialized in transplant. So he was in school, he or her was in school probably until their mid-30s. All our surgeons are trained to manage all parts of transplant, and they usually train in all organs too, so all abdominal organs, so liver, pancreas, kidney sort of get bunched together, but they've certainly had many, many years of schooling. Sometimes transplant surgeons also will do access. I know here one of our general surgeons does the PD catheters, or the majority of them, but some of the transplant surgeons do like to do that, work on fistulas or grafts. Our transplant nephrologists, again, lots of schooling. They've been general practitioners and then gone on to specialize in nephrology. And the transplant nephrologist obviously is experience with transplant specialty. These are the doctors, they do most of the actual hands-on care. Certainly after surgery, the surgeons tend to sort of step back and let the medical people manage. But they're certainly very involved from day one with your care. Your transplant coordinator, this is going to be your cheerleader. This is going to be the person that chastises you if you've not shown up for your appointments. It's the person that you'll work with the closest. Most of the time, this is an RN, but we do have 2 physician assistants that also operate as coordinators. And they're the ones that you're going to get the most education from. They're the ones that you're going to be reaching out to really on a more regular basis than any of the other team members. You'll have their business card with the direct telephone numbers and with their email, etc. Next slide. So as mentioned, we do have a couple of physician's assistants that work in the pre-transplant area as coordinators, but it really is a physician assistant post program. That's the person you will be assigned a PA after your transplant that you will work very, very closely with and have the most contact with. We also have nutritionists. We have two working with us right now, and they're available both for pre and post instruction. And if it's something that you would like to talk to them, certainly let us know. Our social workers are also going to be working very closely with you, and they're going to review and help you with any issues that may arise, things like lodging or transplant, finance, insurance, or legal issues. They're a great resource. We also have two pharmacists on staff, and they're going to certainly, you'll have more exposure with them following your transplant. There is a pharmacist that reviews all your medications before or when you come in initially, but you'll meet with these people and get education face-to-face once you've received your transplant. You actually meet with them in the hospital first, but they'll follow up with you in our outpatient clinic post-transplant. And then the financial coordinators, they will find out when you initially apply. They're going to check, make sure that, first of all, your insurance is on par with the hospital. And if you have any co-pays, that type of thing, how much that will cost per visit, with your medications, how much out-of-pocket expense you may have at the time of transplant, so that you're walking into this with your eyes wide open, and you know if there's going to be a cost, just how much it will be. Next slide. So the other thing, when you're here for your on-site visit, we do blood tests. There's all kinds of things that we look at. Please do not count the tubes. For those of that you have already been through, you're aware that this is it is a lot of blood. You almost need a transfusion when we're done, but every tube is necessary. We have really, cut this back as much as we possibly can. We're looking for the functions of the heart, the kidneys, the liver, the thyroid, the immune system. So there are a lot of issues we want to look at. You're also going to be checked blood sugar, electrolyte balance. There's special tests, the viruses, cytomegalovirus, Epstein-Barr virus, the hepatitis A, B, and C, HIV, the test for AIDS. All these things are going to be done at your initial visit. We also need to confirm your ABO or your blood type. When you're listed primarily by blood type. HLA or the tissue typing, what we're looking for here, this is the genetics that makes you you. There are 6 specific numbers that we look at right now. In the future, this may very well expand, but for right now, there are 6 things that we use to actually place you on the waiting list with. If you have a living donor, we do a cross match, and that's where we mix your blood with the potential donor's blood, and we literally sit and watch it. What happens to the blood cells? If your blood cells attack the donor blood cells, that's what we call a positive cross match, and that is an indicator that there would be a rejection should we use that donor for a transplant for you. But as many of you know, we have donor exchanges now. So, it's nice if a donor can donate directly to you, but it may not be the most beneficial. So that's another test that we do. The serologies I mentioned above, that's the cytomegalovirus. The basic metabolic profile, that's your creatinine, your BUN, sodium, just a sort of very basic test. The CBC is a complete blood count. That's telling us if you have anemia as one of the main things, or infection. It can show if you have a lot of white cells, you've probably got an infection. And then the PT-PTT, this is how well your blood clots. So all these are pretty important to have and know about you at your initial visit. Next slide. So some of the tests that we do, radiology is certainly an important part of our workup. At the chest x-ray, we're just looking at your lungs. We want to check TB. There may be a small spot if you were to have TB. But certainly pneumonias, that type of thing, lung infections, so or disease, COPD, those types of things. It also shows us the size of your heart. If you look in that top right hand chest x-ray, you'll see a bulge sort of right in the middle. Well, the bulge on the right hand side, that is your heart. We do a CT of the abdomen and pelvis. We want to make sure that all the abdominal organs are healthy, that you don't have liver cirrhosis, just as an example, with your liver. We also extend the scan down into your pelvis. If you have polycystic disease and your kidneys are enlarged, we want to be able to see all of the kidney. For everyone, all comers, we also want to take a look at the blood vessels in the pelvis. And the pelvis is lower abdomen. This is where a kidney is actually attached when we're putting a transplant in. And the CT scan does give us a good idea of how healthy or sick those vessels are and whether this is an issue or not. Of course, women have much more to do than men, and so a mammogram for females 40 and older, and that's done annually. Moving to cardiac testing, an EKG is for all comers. Most of you will require an echo. Certainly, if there's any history of hypertension, we're looking at how the walls of your heart move. That would be indicative of something like heart failure. If that's not working well, the heart valves, is there reflux? Is there any problems there? And so it really gives us a good idea how the heart is functioning. A nuclear stress test, while it is a heart test, is looking at something completely different. So again, the echocardiogram, how is the heart pumping? Are the valves all working correctly? And are the walls of the heart all contracting and expanding normally? The stress test is looking to see if you have got blockages within the blood vessels of your heart. So if you have a blockage in your blood vessel in your heart, that is when it could lead to having a heart attack, or it could be angina, those types of things. So that's crucial. Not everyone coming through the program will necessarily need a nuclear stress test, but certainly if there's any history of diabetes, or as you get older, we do feel that is indicated. Carotid Dopplers, this is it's a non-invasive test. It's basically just a sonogram, and it's looking at the blood vessels, the carotid blood vessels, to make sure that there's no blockages. These are the vessels that supply the brain with the blood supply. So we want to make sure all that's healthy. And again, not for everyone, but there are certain times that these things will be indicated. Next slide, Eliza, please. So other routine tests, again, men do get off quite easy. We will be checking a PSA or a prostate-specific antigen. This is in men that are 40 years old and 40 or older, but this is a blood test, so it's just one of the tubes that we will draw when you initially come in. For those 45 and older, male and female, we will need a colonoscopy. The incidence of colon cancer rises dramatically at the age of 45. So we want to make sure, again, that your colon is free of polyps and, preempt any colon cancers there. Again, women pap smear, ages 21 to 29, she got a pap smear every 3 years. It's pap smears for 30 to 65, I believe, or every 5 years. And they do sometimes do the HPV testing along with the pap smear. We also have you meet with other specialists. We are kidney transplant specialists. We are not cardiologists. We're not neurologists or anything else. So if you have an indication and an illness regarding another system in your body, that's something that we may just ask just to get the go ahead, for instance, from your cardiologist. They know that your heart better than we do, and is your heart in good shape, and you can undergo a transplant, that's not contraindicated. And the same would be true for psychiatry if you have an underlying psychiatric illness, hepatology, if you, let's say, have hepatitis B or hepatitis C. We don't want to make a bad situation worse by giving you a kidney transplant, but now we've caused problems for your liver. So this is really why we have you meet all these people. Vascular, we mentioned the blood vessels. If there is a lot of disease in the blood vessels, we want vascular to comment. Is there one place better than another, maybe to put the transplant? But they could help us with that. Urology, this would be for things, a renal cancer maybe, if we were to find on CT scan, or if you've got any kind of bladder issues, we need to get these resolved before you transplant. And then GI, people have got all kinds of GI complaints. The one thing that springs to mind, diabetes, and the absorption is slowed down, and it can cause a lot of vomiting. So it's called gastroparesis. And for someone like that, how are we going to be able to get medications? Those types of issues. So we are looking at, this is a whole jigsaw. This is not one piece or another. It is a whole jigsaw. And we want to know that your entire body is as well prepared as it possibly could be for the transplant. Next slide. So once all those consults and tests have been obtained, what we do is we have a selection meeting. We do this each and every Monday. And the people involved in the meeting are all the transplant team. So the surgeon, the nephrologist, psychiatrist, coordinator, social worker, financial coordinator, and dietitian. And essentially what we do is we go do a complete review of your medical history, your psychosocial history, go over all the medical testing, review the consults, and make sure that the adequate insurance coverage. And any team member could stop being listed. Social work are very important in this meeting. People may seem, if you don't have that caregiver, well, is that such a big deal? It really is. We run into all kinds of problems. The things are put in place for a reason. So everyone has a voice in these meetings, and it's important that we all agree that you can actually go ahead and be put on the list. So once you're listed, you will be notified, and we do send letters to you, also to your dialysis center if you're on dialysis, so they can start to submit a monthly blood test for us. They would draw that while you're on dialysis and send it to us. And also we send a letter to your referring nephrologist so that everyone is aware that you're actually been listed. It's important for the dialysis because they're audited too. So they need to know if you're actually on the list or not. Next slide. So when we're placing you on a list, this list, it's called UNOS, and UNOS stands for the United Network for Organ Sharing. And this is a national organization, federally funded, that runs kidney transplant. They work with the what we call OPOs, the organ procurement organizations, the people that actually go out and harvest the organs. And they also work with the transplant centers such as Cornell. Your data is entered into a computer system, and this is how, or what we refer to as being on the transplant list. During your evaluation, we're going to talk to you about, would you consider being a recipient with a donor for hepatitis C, just as an example. And if you answer yes, then this is where we are able to put these preferences. So that's just one example, and they're all entered in here with you. Your letter is going to outline your responsibilities as a candidate, and really the important things are staying in touch with us. If you have any medical changes, you need to let us know. If you change your insurance, you need to let us know. There's nothing worse than thinking we've got a transplant and you show up and your insurance is completely changed and we don't have any pre-auth or anything else. There's a strong possibility that you may get sent home if this is, an off hours where we can't receive anyone. We don't want you ending up paying for the hospitalization, and these insurance companies are sticklers. So anything like that changes, you need to contact us. And, if in doubt, pull your coordinator, email your coordinator, and we'll get you to the right person. And as mentioned in the past, we do send letters to your dialysis center if applicable and to your physician. If you do not get a letter, then the chances are you're not on that list. So if you're being told, yes, you're being listed, but you don't get a letter within a couple of weeks, then that's certainly another reason to just give them a call, give your coordinator a call and find out what happened. And I cannot stress this enough. You just, again, just a case of reiterating, any changes, call your coordinator. So now you're on the list. Again, we talked a little bit about, your different options that you have when we're putting you on the list. So right now, these are the things that you can opt in or opt out. A kidney donor with hepatitis C. We do not know 100% that the donor would even transmit that hepatitis C to you, but what we do is we watch you, and you will be treated with the medication to treat hepatitis C. It's an 8-week treatment and it cures hepatitis C. So if that's an option you're comfortable with, that certainly, again, opens it up and it can shorten your waiting time. The expanded criteria donor, that is a donor that's generally from an old type donor. We scale things from 0 to 100 for the donors. And, a number is assigned, and anything with 85 or above is regarded as this expanded criteria donor. We give you the specifics. We tell you if they've had, a medical history. We tell you what the creatinine is. We tell you what, how old they are, all those types of things. So you can still, you still get to make the decision. But for people that know categorically they're not going to be interested in accepting that type of donor, they can decline that option, and then we won't be calling you with that. My recommendation personally is keep your options open. I think that, as you spend 2 or 3 years on dialysis, each year to you becomes more and more important, and it can significantly shorten your waiting time. So I do think that's something to at least think about. The other thing that can be done is multi-listing. The regulations recently changed back in March of 2021. And before that, our OPO, Organ Procurement Organization, essentially just covered the New York area, the immediate New York area, Long Island, sort of halfway up to Albany, all of Brooklyn, all of the Bronx, all of Staten Island. And that was the area where kidneys were offered to us primarily. What changed in 2021 was that area was increased. It is now a 250 nautical mile, which translates, I think, is 280 regular miles. And that takes us south of Washington, all the way north of Boston, and we can be primary on those lists. So multi-listing within that area is less significant than it used to be. Before, you just had to basically cross the Hudson, go to New Jersey, and that was a completely separate list. Well, it's taken that out of it. It was recognized that New York had a longer waiting time than the surrounding areas. That is why these changes came in. It's trying to equalize everything on this playing field. It's not there yet, but it's better. Our wait times on average were cut back by about 2 years when this happened. So it's not a perfect solution, but it's certainly better than it was. Now, things to keep in mind. Number one, your insurance. Does your insurance pay for you to go to that specific center? Number two, you're going to be away from home for 3 months. Even if people come here, we want to manage their immediate care for 3 months following that transplant. You're our responsibility, you're our statistic, and we want it to be a success. So we're not going to just let you wander off and go and have a doctor that's not really up on transplant take care of your kidney. So other centers are the same. So if you're going to Texas, then the chances are they're going to want to keep you in Texas for 3 months. They will let you come back and follow up with your care here after 3 months, but for the first 12 weeks, you are going to be staying put. So how can you afford to do that? What I recommend to people, where do you have family? If you have family that live in Texas, or they live in, any area outside of the 280 miles. So Florida is another place that you could certainly list. Then that is certainly the way to go. Just so that you know, the shortest waiting times for all blood groups on average is in Nevada and in the Midwest. And anyone that's interested, there is a wonderful resource you can check with your blood group at this website at multilisting.com, and it will tell you the average wait time, and you can compare all the different centers and see where is the shortest waiting time for your blood group. Next slide. Stay the course. There's certain things, certain messages that I try and get across. Early referral, get here before your GFR is 20. Don't give up on as you're trying to get on the list. One test can be positive, which then ends up leading to getting another test. Yes, it's frustrating, but you've got to be in this to win. You've got to be on the list to be able to get a transplant. And all I can say is, once you get that transplant, it's like women talk about childbirth. You forget it all once the baby's born. I think it's the same with transplant. A lot of legwork needs to be put in. It can be frustrating, but it is worth it. Communication. You've got the direct telephone number and email address for your coordinator. If there's any doubt about anything, just drop an email or give them a call. There's a lot. You're hit with a lot of information when you first come through. So, we don't want you to just give up and get frustrated. And one of the things that I do see is, if people come with a donor and then the donor rules out, they give up completely. Well, get yourself on the list. Again, you've got to be in it to win. You just never know what may happen. Once you're on the list, you need to stay in good standing. So again, drop your coordinator an email every 6 months. Hey, am I okay? Is there anything you need? Or if you've had a test, updated a colonoscopy, or you've just done a mammogram, don't wait to be asked. Send it in to your coordinator. Again, be proactive about this. You do not want to miss the opportunity of a transplant, because you're not staying up to date with your testing. Demographics. I've had this happen where I've been on call and I've had a great offer for a specific patient, and can I find them? The telephone numbers are not the same. Nobody's responding to email at 2 a.m, and we've missed opportunities at transplant. So any changes whatsoever, it's vital to let us know, including your dialysis center, because they are sending us monthly blood specimens so we can do cross matches behind the scenes. Okay, we don't necessarily call for every single donor, but sometimes we'll do cross matches on the off chance it could come to you. Put the waiting to good use. I know it's easy to say and it's difficult to do, but you got to keep yourself healthy. Try and adopt a healthier lifestyle. Go for a walk once a day. Whatever it is that you can do to help yourself, this is a good time to do it. The better that you go into a transplant and the healthier you are, the better off you're going to be afterwards. and continue looking for a donor. Don't give up. Miracles happen. Just talking about it. You don't necessarily have to go out and say things like, I need a donor and I need one now. What you can do is just open the conversation, and then it's amazing. Some people will say, hey, I've got 2 kidneys. I'll get tested. You don't know. You got to go there for it to happen. Next slide. The surgery itself takes about 2 to 4 hours. You wait in recovery room 6 to 12 hours, and then you'll be transplanted to a regular floor. That you don't need an ICU stay. As you can see on the diagrams on the right, your native kidneys stay in unless otherwise indicated. And people, you're usually in the hospital 4 to 6 days. And that's not because you're sick, it's because we need to get your medications adjusted. Education is going to start the second really that hit the hospital about how to take care of your transplant. It's possible you may need dialysis the first few days, but that certainly does not mean that the kidney's not going to work. This is just called delayed graft function and actually occurs in about 40% of patients. We're running a little late, so I'm going to go a little faster. And sorry, next slide. And the post-transplant surgery, the follow-up is done both with video and in-person visits. The further or more distant from the transplant, the less frequent your visits will be. Care is shared with your referring nephrologist, and after the 3-month mark, we do alternate visits with them, and we will transfer you back to the community as soon as you can. We do have, are we still going to be doing this presentation post-transplant? I guess so, right?
Yeah, we have that coming up.
Okay.
But I just wanted to share it for people just to know that it's there on our website. Maybe we'll skip past this question point and please type in your questions. We'll get to it at the end, all of our questions, just because, yeah, we are running a little bit behind. Judith, that was amazing. I think it was very informative and all those things you cover are very important. So please, again, type in your questions in the chat box and we'll cover them. I'm going to cover just a little bit more on my specialty, which is trying to help people find a living donor if they are looking for strategies. So we're just going to do a little fact versus fiction. Many of you already attending probably know the answers, but we'll give this a go. So true or false, does your donor need to be the same blood type? And I understand people aren't going to possibly be answering, but that's okay. So false, if you're blood group compatible, the person can donate directly. If they're not compatible, we thankfully have the donor exchange program. So we always tell patients, because sometimes people get bogged down on trying to find a donor who's their matching blood type. We say, listen, all you need is a willing, healthy, able person to come forward and get tested and let us handle the rest, because we have so many options, especially given that we have the paired exchange program with the NKR. True or false, there's an age cutoff for a living kidney donor. False. We have had living donors donate in their mid-80s. Yes, that's not the most common situation, but we tell recipients all the time, never rule out your donors. Let us do that. Potential donors, don't rule yourself out. If anyone on the line is a potential donor, don't rule yourself out based on your age, or if you have certain disease types that you think could cancel you out. Let us do that. We do have a minimum age of 21 years old. Nationally, donors, it's 18, but at Weill Cornell, we do stick to the 21 years old. You can still have children after donating, true or false? True. So pregnancy obviously should be discussed with your OB before commencing, to make sure, you're not at risk for preeclampsia and certain, scenarios where you might have high blood pressure, but you can definitely still donate. And actually people on the other flip side who have had a transplant can also have children. And so all of that just needs to be really discussed with your provider and making sure that they're aware of your circumstances. So once you donate a kidney, you are left with only half of your kidney function. True or false? False. Your remaining kidney will compensate, your remaining kidney will grow, and at 6 months post-donation, you'll have around 75%. And as we know, donors can live long, healthy lives with one kidney. We wouldn't have living donation if there was a significant risk to the donor. So the body is incredible. And the fact that your kidney compensates, your remaining kidney compensates and takes over the job is wonderful. And that's why we have living donation. True or false? Living donors need to be in good health. True. Certain conditions such as diabetes, amongst others, can rule a donor candidate out. But again, our job is to make sure the donor is able to move forward. You are never to rule someone out. And as you may know, the candidates go through an extensive health questionnaire in the beginning, and then they have an extensive evaluation where we're looking at everything. Even people who have some level of high blood pressure, it depends on how many medications they may be on. Like, it really all depends. So our team looks at the donor holistically and makes sure that it's a good move for the donor. And if we have any concerns, we will likely not clear them. True or false? Your donor needs to have a biological or emotional relationship to you. False. We have altruistic donors or good Samaritan donors that have never met recipients. And we know that you don't need to be biologically related to your donor because we are able to look at patients' HLA and making sure they have a good cross match. We also have the paired exchange program. So one thing to note, it is illegal to pay an organ donor, but you can assist with their expenses. If you have any questions about the financial element, we can talk about it. Your donor is given a financial coordinator where a lot of these things are explained. There's wage reimbursement for when patients donate. There's a lot of support, especially with Donor Shield, which we'll talk about in a little. Okay, so finding a donor. So if you're attending this webinar and you do not have a donor, what are some ways you can start to begin that process? So you're in the right spot because you're learning about living donation. Education is power. We want you to be able to talk about kidney disease and what it means to be a living donor clearly and concisely. This way you can confidently share facts about living donation with friends, family, and potential donors. Again, like Judith said, you can start that conversation. And then you can also guide your potential donors to learn more. But the more you know, the better position you'll be in. You should write your story. So why do you need a transplant? What led you to this pathway? What battles have you had in your life? And sharing what it's like to live with kidney disease. The chances are that many people have no idea what it's like to live with kidney disease or what it's like to live on dialysis. And then also some people might just not know living donation even exists, believe it or not. If you're not impacted by kidney disease or aware of living donation, chances are you probably don't know much about it. And that can be a lot of people in this world. So writing your story, sharing it, getting the word out is a really eye-opening process for many people who have never even heard of kidney disease or living donation. This is your opportunity to be honest and sharing your story. Step 3, again, you never know who might read your story and be motivated to help. We have had so many people come forward. One specific patient was walking through an airport and heard a news story about someone who needed a transplant, and they had never heard about living donation before. And they decided, you know what, let me get tested. And they were across the country and they were able to help our patient. Another scenario of a donor I spoke to, they went with their family member to the kidney evaluation and they didn't even know that living donation was an option. So they then learned more and they became a living donor for their loved one. It's just about turning the lights on. Designating a kidney champion, step 4. That's something I recommend to all of our patients. Listen, if you're a recipient and if, say, you're on dialysis, you're battling this chronic disease, finding a donor is a huge, huge endeavor. And it's a lot of pressure, and it can also be a lot on your plate. So having someone in your life who may not be able to donate to you for whatever reason, but wants to help you, can help ease the burden. They can offer you emotional support. They can help share your story, and they'll feel less uncomfortable asking because they're asking on your behalf. And it's often easier for someone to say, hey, can you help out my friend? Can you share her story? Can you post this to social media for my friend? And it just takes the load off. So make sure you have a donor kidney champion in your life if you can. We want you to create a microsite. If you're on our list, it is a valuable tool. It is a free tool for finding a living donor. We know that living donation is the best option, and the microsite is a free website that is very easy to create. You can add photos, you can add why you need a kidney. The compelling component of the microsite is the photos. I love reading the emotional connection and finding out what this person went through. But the microsite is also great because there's support and protection education listed. So anyone who's viewing the site, if they're interested in learning more, they can click on what it means to be a voucher donor, what it means to donate remotely, what it means to have Donor Shield. And it's just a very nice tool. And it was actually Dr. Kapoor's idea, so we have to take credit for that. How can you use your microsite? Pretty simply, once you register and create the site, you can share it on social media through email. You can also, you get business cards that come with the site, and you can place them in local community areas, a YMCA, a place of worship, anywhere you think, a coffee shop. Really, at this point, we are telling patients that just leave no stone unturned and try to get people to your microsite just to see if they want to learn more, if they want to consider donation. And again, one of the great things about the microsite is you get a donor search coach. So someone who has helped a loved one or has been a donor themselves is going to be there to guide you to talk more about this. So our donor coach at our program is a woman named Terry Bennett. She's amazing. She helped her son find a living kidney donor, and she is always available. So if you're on the call, you don't have a microsite, or you just want to talk to Terry, let me know. Judith or myself can get you connected to Terry. If you are interested in speaking to someone who speaks Spanish, we have our other coach named EJ. He's a living donor. So we have a lot of tools, and connection is really important. And other resources, we obviously have our website with a ton of information. We have our Living Donor Kidney Center. We have the Big Ask Big Give, which is a workshop that we've done where we've actually had a donor. We had Mike Lolo attend, and then we had one of our recipients, Gisela Delgado, who had a beautiful media campaign launched, and she gives a lot of tools and tricks on how she did it. And it's on our website. You can watch it. It's about an hour and a half. So please take the time. It's there. Again, we love the Big Ask Big Give. All right. So reflecting on, I know Judith had shared our earlier stats of our year from 2023, but we did have the highest volume year in our history. We celebrated our 60th anniversary. We continue to be #1 in New York for living donor kidney transplants. And we've been really busy, which is great. It means we're getting patients off the list. We're getting them transplanted. They're doing well. And I know we're going to continue to do great work. We have had a ton of deceased donor transplants thanks to the new allocation system, which Judith explained. We've been really busy. I was just on call 2 nights ago, and it's really the most wonderful feeling is calling a patient and saying we have a kidney for them. So keep your eval up to date, your listing, make sure you're communicating with your coordinator, making sure all of your testing is up to date, and making sure you're able to get an organ offer if you don't have a living donor. Just another reflection of our 60 years. This was a collage that we did, and you can see some of our amazing patients and our team members, and we're just really appreciative for everyone who makes this job possible. Our website, in case you haven't been, I hope you have been, it's weill-cornell-transplant.org. We have patient stories there. We have a lot of education. We have resources, and just go. And if you have any questions, please, or suggestions, feedback, let us know. Judith and I are always looking for feedback. We want to provide you with content that you find valuable and interesting. So please let us know. Here's our contact information. Here's some of the websites that we talked about today. And we really appreciate you taking the time to join us. We, I think, have one question. Oh, these slides are wonderful. Can you email the slides? Yes, we'll email the slides. We'll email you the recording of the presentation. Judith, I wanted to actually show our next, as you may have noticed, we rebranded. We are Virtual Insights on Kidney Transplantation. We're very excited about it. This is our upcoming agenda. So next month, we're going to have like real conversations with some of our transplant recipients, which I think will be really interesting. Then we're going to talk to some of our living donors. We'll then talk about paired exchange, which everyone should learn about. It is so important to learn about paired exchange, the voucher program, all of these options. We'll talk about low eplet mismatch. We'll talk about all of these really, really important new innovations. Then we'll have post-transplant medications, very important for our post patients. Even if you're not post yet, join, because you will be. We're going to get you a transplant. And we'll talk about nutrition, managing that, the mental health and well-being, supporting our recipients, supporting our pre-transplant patients. And then we're going to talk about pediatric transplants if you're interested. And then we will cover a comprehensive review. And that takes us into November 2024. And please send us feedback if you want more topics. Judith and I are really passionate about this. We really pour our heart and soul into these conversations, and let us know what you want to hear about. So thank you again. And wow, wait, it is 12:04. I'm going to let everyone go.
Thank you all so much for joining us today. And as Eliza said, we will be sending out the presentation. Have a wonderful day, everyone. Thank you.
Thank you. Bye.
Bye, everyone. Bye-bye.